afternoon, wherever you are in the world. This talk in the Adaptive Platform Trial webinar series. And it's also my pleasure to introduce Dr. Bruno Ferreyro, who will be giving today's talk. He's an assistant professor in the Interdepartmental Division of Critical Care Medicine and an intensivist in the Sinai Health System here in Toronto. Originally from Buenos Aires, Argentina, where he completed medical school and internal medicine training. And then he came to Toronto, trained in critical care medicine, also obtained a PhD in clinical epidemiology. His clinical and research interests include acute respiratory failure, non-invasive respiratory support, and critical illness in immunocompromised patients. And today, Dr. Ferreyro is going to be talking about non-invasive respiratory support for patients with respiratory failure. Dr. Ferreyro, welcome, and the floor is yours.
Hi, good morning, everyone. Hi, Richard. Thank you very much for the kind introduction. I'm so happy to be here to present today. So I'm going to start moving forward. I do not have any important disclosures or conflicts of interest related to these talks. I do have some funding from CIHR and the Interdepartmental Division of Critical Care Medicine that really have no influence on this talk. And I hope that in the next 45, 50 minutes, I can talk about the role of non-invasive respiratory support for patients with respiratory failure, describing some typical clinical scenarios, rationale, which are the devices and modes, moving then to the evidence and describing the physiologic evidence to the clinical evidence, mainly stemming from randomized controlled trials, with some guidelines on precision medicine in this field, describing some particular characteristics of the patients that might help us decide between one device and the other. Moving later to the importance and methods for monitoring, and finally some future directions describing some areas of uncertainty and some ongoing research we are conducting in the area. So the use of non-invasive respiratory support, I would say, has an established role throughout the trajectory of patients with respiratory failure. Early on, in the early phases of respiratory failure, mainly for the prevention of intubation or to support patients when they are still not intubated. And for that purpose, we could define that it's key to identify which is the primary cause of respiratory failure, if it's acute hypoxemic, hypercapnic, or congestive heart failure as the primary etiology of respiratory failure. The second scenario where non-invasive respiratory support has an established role is during the intubation itself. And as many of you are aware, the use of non-invasive respiratory support has shown some effectiveness in decreasing the risk of adverse events during the procedure of intubation itself. And then following an episode of invasive mechanical ventilation when patients are extubated and during the weaning process, it has an established role mainly for the prevention of extubation failure. Most of my talk and most of the clinical evidence discussed today will focus mainly in these early phases and for hypoxemic respiratory failure in particular. So let's describe a little bit the rationale of using non-invasive respiratory support. We usually conceptualize invasive mechanical ventilation not as a treatment per se, but rather a supportive measurement to facilitate gas exchange while lungs recover from the initial lung injury. In a similar way, we could also conceive non-invasive respiratory support to provide support leading to recovery without the need of invasive mechanical ventilation. Also, a key principle in the management of acute respiratory failure is to decrease what is called the secondary lung injury that can prevent patients from achieving recovery. So in the last 20 years, we have learned that excessive spontaneous breathing in patients with respiratory failure might be harmful by several mechanisms, namely by leading to high transpulmonary pressures, increasing types of diaphragmatic load, and leading to mechanisms known as Pendeluft. Many of these concepts have been conceptualized under the umbrella term of patient self-inflicted lung injury. As we will see in the next few slides, different types of non-invasive respiratory support not only can be supportive strategies, but can modulate these secondary mechanisms of lung injury associated with high inspiratory effort and excessive spontaneous breathing. So as such, we could conceptualize non-invasive respiratory support not only as a support strategy, but also as one that can mitigate some of the key secondary mechanisms of lung injury. And truly, it's also important to recognize that there is likely a spectrum where the use of non-invasive respiratory support is optimal, that is described in this figure. So on the one side, on the left side, on the green side of the spectrum, non-invasive respiratory support is used safely to support safe spontaneous breathing, keeping patients awake, interactive, and comfortable throughout the trajectory of respiratory failure. Whereas at the far end of the spectrum, continuing inappropriate use of non-invasive respiratory support might also be harmful by delaying intubation, by perpetrating patient self-inflicted lung injury, poorly controlling the tidal volumes that the patients are taking. And in that end of the spectrum, the favors go towards moving to invasive mechanical ventilation. I would argue that it's one of the main clinical challenges of managing these patients, recognizing where we are in the spectrum and knowing when to move from one side to the other. These are the available devices that we have for non-invasive respiratory support. Broadly, they can be classified in standard oxygen therapy, low-flow nasal cannula, Venturi mask, non-rebreathers, non-invasive ventilation that can come with broadly two main types of interface, one that covers the mouth and the nose, which is the face mask interface or orofacial interface, and one that covers, it's a hood that covers the whole head, and that's the helmet interface. Each of these interfaces can be used to deliver different modes of ventilation, mainly continuous positive pressure or two levels of ventilation, either BiPAP or bi-level non-invasive ventilation, or in some terms, non-invasive ventilation itself. The last device that came to play around 10 years ago is high-flow nasal oxygen. Going a little bit through a historical perspective, we could say that before the year 2000, the main method to support patients with acute respiratory failure was standard oxygen therapy, with non-invasive ventilation, in particular for patients with acute hypoxemic respiratory failure, becoming more popular after the year 2000. In more recent years, and in particular after the year 2015, high-flow nasal oxygen really came into play, and I would say after COVID-19, really come to dominate the field and be, at least in developed countries, the most used method to provide non-invasive respiratory support. And helmet non-invasive ventilation, despite it's not a new device and not a new strategy, has been gaining interest and enthusiasm in the last few years with some emerging evidence that I will describe. So let's talk a little bit about the main physiologic mechanisms. The main mechanisms of how high-flow nasal oxygen might provide benefit in patients with acute respiratory failure is nicely described in this editorial from Iwan Golliger and Art Slatsky, mainly by the application of humidified gas that might lead to better secretion clearance, provide some flushing of the upper airways, decreasing the anatomical dead space. In particular, and I would argue perhaps the most important mechanism of high-flow nasal oxygen associated with the high flow itself, that can both improve the dynamic compliance, but also lead to less entrainment of room air in a patient that has high respiratory demands and is typically taking itself very high inspiratory flows, ultimately leading to a more effective FiO2 delivery in the lower airways. Finally, and perhaps less important in patients that have their mouth closed, it can also provide very gentle positive pressure, potentially helping to recruit atelectatic regions of the lungs. Helmet non-invasive ventilation has very unique physiologic mechanisms. You can see my friend Dr. Angreman from Salinbrook very happy here wearing the helmet. But the main difference, and when I say the main difference, I need to focus on the main difference with the face mask NIV, is that it can provide both continuous positive pressure and bi-level pressure in the airways with minimal leaks. I think everybody is familiar that when you're using a face mask and you try to increase your PEEP levels beyond 8-10 centimeters of water, patients start to experience a lot of air leaks throughout the interface because the seal is really not very effective to prevent leak when the airway pressures that we want to use, or in particular when the PEEP that we want to use is higher. The seal with the helmet happens specifically at the level of the neck, And for that reason, the helmet is much more effective to provide higher levels of PEEP. There are also other potential secondary benefits of the helmet, which were important during the COVID pandemic. That is the lower risk of aerosol dispersion, because most of the flow happens within a closed system, and because of the decreased air leak, there's a lower risk of aerosol dispersion and transmission of respiratory diseases. Perhaps this is one of the landmarks clinical studies showing benefits of helmet NIV. This study was conducted in Chicago in the year 2016. And what they did was randomize patients with acute respiratory failure that were receiving face mask NIV to continue on the face mask or to be switched to a helmet. And they showed a spectacular reduction of intubation, 40% absolute risk reduction of intubation with the helmet. The study is a single center study. It was stopped early. The protocol changed throughout the period. So there are some limitations, but definitely a really important and enthusiastic effect size that led to more research in this area. When comparing helmet NIV to high flow nasal oxygen, this is a very nice physiologic study conducted in Italy. And what they showed is that when patients with acute hypoxemic respiratory failure receiving high flow nasal oxygen were switched to a helmet interface, there was a significant reduction on the inspiratory effort, perhaps because of the higher PEEP that can be applied with the helmet and the more effective PEEP. And interestingly, despite providing non-invasive ventilation, 2 levels of ventilation with the helmet, the transpulmonary driving pressures did not result increase with the helmet as compared to the high flow nasal oxygen, which suggests that this is likely due to the reduction of the inspiratory effort. The resulting transpulmonary driving pressure did not see a significant increase. More recent physiologic evidence on different devices for non-invasive respiratory support showed that when moving from high flow nasal oxygen to helmet CPAP and helmet use with a non-invasive ventilation mode, so with a bi-level ventilation mode, the reduction of the inspiratory effort was highest among patients receiving helmet. The percentage of Pendeluft and the dynamic strain were all lower with the helmet interface. So at least strong physiologic evidence that the helmet can decrease inspiratory effort and potential secondary mechanisms of lung injury compared to both high flow and to CPAP delivered by the helmet itself. So to summarize some of these physiologic mechanisms, I would say that there's a wide range of physiologic effects of the different non-invasive respiratory strategy modalities, that high flow nasal oxygen can decrease the inspiratory effort compared to standard oxygen, but in particular, helmet NIV delivered with a bi-level mode of ventilation is perhaps the most effective to reduce the inspiratory effort when compared to any other strategy. Maybe because it allows for higher and potentially more effective PEEP than, for example, a face mask. In the next few slides, I will describe a bit of the key clinical evidence in this field. Again, really focusing on the early phases of respiratory failure and in particular for hypoxemic respiratory failure. So it's really not possible to talk about the evidence around the use of high flow nasal oxygen and non-invasive respiratory support without mentioning this landmark study. This is the Ferreyro study published in New England Journal of Medicine in the year 2015. And I would say that it's one of the large responsibles for the wide incorporation of high flow nasal oxygen into daily practice. What it showed is patients were randomized to non-invasive ventilation via face mask, standard oxygen, and high flow nasal oxygen, and it showed a significant reduction of intubation in patients with high flow nasal oxygen. In particular, when we look at those with moderate to severe respiratory failure, as measured by the PF ratio, and a significant reduction in the risk of all-cause mortality with high flow nasal oxygen. The other interesting finding of Ferreyro is that the group that seemed to do worse were those patients receiving face mask NIV, which by the time was in many centers around the world, one of the perhaps standard of care for supporting patients with acute respiratory failure that were not intubated. And this, with other immersion evidence from observational studies, started to bring a word of caution in the use, in particular in the use of face mask non-invasive ventilation in patients with early acute respiratory failure, and some concerns that perhaps the lack of capacity of face masks to really control the tidal volumes could lead to further lung injury and worse outcomes in these patients. With a group of colleagues in Toronto a few years ago now, and this is right before COVID, we conducted a systematic review and network meta-analysis trying to summarize and capture all the evidence and try to come up with pooled effect estimates for all these interventions. And what we observed is that when compared with standard oxygen, and in particular for the outcome of intubation, the three strategies, namely high flow nasal oxygen and non-invasive ventilation delivered either with a helmet or a face mask, were effective to decrease the risk of intubation. A particular limitation was that when we conducted multiple sensitivity analysis and assessed how robust were these findings, we observed that for face mask NIV, this finding did not really hold when assessing multiple sensitivity analysis. So, for example, when we included only studies that had more severe forms of lung injury, or excluded studies that had included within the definition of respiratory failure patients with congestive heart failure or COPD exacerbations that are known interventions that benefit from face mask, CPAP, or NIV, when we excluded those studies, the beneficial effects of face mask NIV were no longer seen. So this somehow we felt was consistent with what was suggested in the Ferreyro study. The other interesting finding of our systematic review is that it seemed that the most effective and the most pronounced benefit were seen in particular for helmet non-invasive ventilation, either when it was compared to standard oxygen or even compared to high flow nasal oxygen and face mask non-invasive ventilation. But a unique limitation is that, as you can see here, despite the effect estimates for helmet NIV are a bit more pronounced and more protective, the point estimate itself, the credible intervals were much wider, so we had less certainty on those findings. And when assessing the quality of the studies leading to these effect estimates, we could only conclude that the evidence or the certainty in our evidence was low. So after all this, high flow nasal oxygen really made it into the guidelines and gained its strong recommendation for the standard of care in patients with acute hypoxemic respiratory failure, which I would argue is slightly reflected by usual practice, at least in developed countries. COVID-19 came as a storm and also came as a great opportunity to study this field. And this is just one selection of the most important randomized controlled studies that studied different non-invasive respiratory support devices in patients with acute respiratory failure during COVID-19. Perhaps I would like to highlight some of these studies. So this was one of the helmet studies. So, and this was actually the first helmet versus high flow nasal oxygen study randomized controls trial conducted, which showed essentially that helmet NIV had a significant reduction of intubation when compared to high flow nasal oxygen. And this study was conducted by Domenico Greco in Italy. Perhaps the largest randomized control trial conducted in the area of COVID was the Recovery Respiratory Support RCT conducted in the UK and other countries, comparing high flow nasal oxygen, CPAP, mainly delivered by a face mask, and standard oxygen. And what they showed is that CPAP was superior to standard oxygen to decrease the risk of the combined outcome, intubation and mortality. And high flow nasal oxygen did not really show a significant difference compared to standard oxygen. Perhaps this being the largest evidence brings a bit more of an argument to use CPAP in the special context of COVID-19, although this has not really translated into practice in many centers. More recently, Kevin Lee and Chris Ernell and their group conducted this year, just published a very large randomized controlled trials looking at the effectiveness of different non-invasive respiratory support strategies and updating our previous meta-analysis now with 44 randomized controlled trials and included COVID-19. So really the largest meta-analysis conducted to date, almost 10,000 patients representing this study, and showing similar findings in terms of the effectiveness of the different interventions. It seems that non-invasive ventilation, CPAP, and high-flow nasal oxygen are more effective than standard oxygen therapy for clinical outcomes, in particular for intubation. And perhaps the one salient aspect of this study is that they really focused on the criteria for intubation, and they divided studies on whether they had explicit criteria for intubation. And one of the questions that they were interested was whether the criteria for intubation or having criteria for intubation was a factor that could modify the relative effect of these interventions. And the answer was no. So interestingly, these findings really apply to centers and places where people use explicit criteria for intubation or not. The most two recent trials that were published in this field are the Renovate RCT, and more recently this year, Frat and colleagues, the same similar group to the one that published Ferreyro 10 years ago, replicated the study now with the aim to try to find a significant difference for mortality, comparing only high-flow nasal oxygen to standard oxygen therapy. So after learning the potential harms associated with face mask NIV, they dropped that arm and only conducted a two-arm RCT. And essentially, they showed that there was not a significant reduction of mortality with high-flow nasal oxygen, but confirmed what we really knew, that high-flow nasal oxygen, when compared to standard oxygen, did show a significant reduction of the requirement of endotracheal intubation. ARDS guidelines, European ARDS guidelines do have a specific couple of questions in the use of non-invasive respiratory support for patients with ARDS and acute hypoxemic respiratory failure. And they do a strong recommendation for high-flow nasal oxygen, mainly to prevent intubation, not for mortality, and no recommendation really between high-flow nasal oxygen and CPAP NIV. No recommendation for CPAP NIV versus standard oxygen, maybe a weak one for CPAP in the context of COVID-19, likely driven by the recovery ARDS study that I described before, and really no recommendation for helmet NIV, but one comment that perhaps this is a strategy that needs to be studied with a bit more detail. So just to summarize here in my 2 cents of the very complex and wide evidence from RCTs in this field, I would say that for endotracheal intubation and compared to standard oxygen, high-flow nasal oxygen has robust evidence of benefit. Non-invasive ventilation or bilevel non-invasive ventilation and CPAP have some evidence of benefit, but it's less robust than high-flow nasal oxygen. And helmet NIV is promising, but it's somehow limited by small studies, single center, or studies that have been conducted in centers that have a very strong preference and long-standing experience with this intervention. However, for mortality and when compared to standard oxygen, the benefits of these different non-invasive respiratory support strategies are less clear. Importantly, I would say that we need to be cautious because intubation as an outcome has some limitations. After all, it's a clinical decision that can be influenced by different factors. So it's not definitely as hard as an outcome as mortality. And of course, none of these RCTs are blinded. It's almost impossible, if not impossible, to blind this type of studies in this field. So this somehow is a basic factor that limits the overall conclusions that we can make, in particular when talking about an outcome that can be influenced by clinical decision like intubation. I would argue that the lack of blinding can less influence a hard outcome of mortality. And the classic question that we all ask, and I think it's one of the main aims of the practical platform, which is that's really one size fits all. Are there any particular differences that patients can exhibit that would make them more amenable for one strategy over the other. And that's going to be the topic of my next few slides, describing some evidence of precision medicine or sources of heterogeneity of treatment effect. So from a theoretical point of view, we could say that the sources of heterogeneity of treatment effect can be based either on patient characteristics. We could say, for example, the etiology of respiratory failure might help us decide from one device to the other, whether the patient is immunocompromised or not, whether subphenotypes that have been nicely and largely described, in particular in patients with receiving invasive mechanical ventilation and showing some potential for differential effects of treatments in patients receiving invasive mechanical ventilation could perhaps be a source of heterogeneity of treatment effect also for non-invasive respiratory support strategies. The severity of disease, either as a prognostic or predictive enrichment source, and those two that I would highlight are the degree of hypoxemia and the levels of baseline PCO2, and in particular, the inspiratory effort. As I mentioned before during the physiologic description, we know that helmet non-invasive ventilation seems to be a bit more effective to control inspiratory effort, and we know that patients with respiratory failure exhibit a wide range of inspiratory effort levels. So perhaps if we had better tools to identify those patients that have a higher inspiratory effort at baseline, those are the ones where it's worth going to a more advanced approach with a helmet NIV, and perhaps those patients that have lower inspiratory effort at baseline can just benefit with high flow nasal oxygen or even standard oxygen. This is at least some evidence that the baseline PCO2 could be an important effect modifier, of the effectiveness of these interventions. This is a secondary analysis of the Hennebo trial, the one comparing helmet, NIV, and high flow nasal oxygen in patients with COVID-19. And what they did here was redo the analysis and divide patients on those that had a normal PCO2 at baseline and those that had a low PCO2 at baseline. And what they observed is that the beneficial effect of helmet NIV when compared to high flow nasal oxygen was dramatically exacerbated when looking with a lens at those patients with a lower baseline PCO2. So when they looked on the right side of the screen, when they looked at patients that had a low a PCO2 less than 35 at baseline, they observed that the reduction of the risk of intubation was much higher for helmet NIV. And the theory behind this is that perhaps baseline PCO2 is a surrogate marker of patients' baseline effort and drive, and this is a way to recognize those patients that physiologically benefit more from an intervention like the helmet. Immunocompromised patients has been a topic of interest personally for many, many years, and I still struggle to identify whether really immunocompromised patients are a population that would benefit more from one strategy or the other. We could definitely argue that these patients have a higher medical complexity that mainly is driven by the multiple etiologies that can lead to respiratory failure, which typically requires a very thorough diagnostic approach. And if these patients require invasive mechanical ventilation, there's pretty good literature to show that these patients experience worse outcomes than non-immunocompromised patients. In the early 2000s, there were a number of small studies that showed that perhaps non-invasive ventilation and CPAP were more beneficial in these patients. This was in the pre-high flow nasal oxygen era and has really not been replicated by recent literature. And maybe I would leave this question for discussion at the end, but I still cannot find a biologic rationale or clinical evidence that these patients would have a distinct response to certain strategy compared to the other. And I would say that this does not worth enough evidence to make unique and distinct recommendations in these patients. As I said before, I was going to focus most of my talk on the prevention of intubation in hypoxemic respiratory failure. I just thought that at least I would do a couple of comments on hypercapnic respiratory failure because I think there's some exciting evidence emerging. Everybody knows that for patients with hypercapnic respiratory failure, non-invasive ventilation, bilevel in particular, non-invasive ventilation has been, and I would say still is, the cornerstone of non-invasive respiratory support. But in the most recent years, there has been some immersion randomized controlled trials using high-flow nasal oxygen and showing some promise. But some important caveats are the following. Most of the randomized controlled trials looking at high-flow nasal oxygen in hypercapnic respiratory failure have looked at patients only with mild acidemia. And maybe the threshold to define mild acidemia is, in particular, the pH in the RCTs looking at high-flow nasal oxygen in this context have included patients consistently with pH above 7.25. And importantly, even though they showed some promise and some evidence, the crossover rates from high-flow nasal oxygen arms to non-invasive ventilation are quite significant, are around 30% in most of these studies. The one clinical conclusion that I take from this is that if we're going to use high-flow nasal oxygen in patients with hypercapnia, we would still do so in a setting where we can look at the patients closely and have non-invasive available for escalation if needed. The other interesting thing that might differ from hypoxemic respiratory failure, where we typically start at very high flows on high-flow nasal oxygen, is that there is some physiologic evidence that suggests that in patients with hypercapnia, the optimal flows for high-flow nasal oxygen might be around the 30 to 40 liters per minute and not the 60, 70 that we use in patients with hypoxemia. Sorry for the typo there. Lastly, the last scenario that I would like to describe is the prevention of intubation. As I said before, non-invasive respiratory support has also an established role in the weaning process once we extubate patients and want to decrease the risk of reintubation. And I would frame the use of non-invasive respiratory support in three different settings. In patients that we want to prevent failure but have low to moderate risk, and perhaps we can also discuss at the end some of the limitations of defining low, moderate, and high risk. But in those patients, it seems that high-flow nasal oxygen compared to other strategies, in particular compared to standard oxygen or room air, has some beneficial effect in the prevention of extubation failure. Now, in patients with high risk, and patients with high risk are essentially patients that are older, that have coexistent heart or respiratory disease at baseline, patients that have high BMI, patients that have been ventilated for acute hypoxemic respiratory failure for a prolonged period of time. It seems that the combination of high-flow nasal oxygen and small sessions of non-invasive ventilation with a face mask seems to be more effective than high-flow nasal oxygen alone to decrease the risk of extubation failure. Finally, in those patients that we extubate and they suddenly develop new onset acute respiratory failure, so this is a completely different scenario to the two others that I described, there's probably no role for non-invasive respiratory support, and except very selected cases, most of the times the right answer is to reintubate those patients. So let's move to monitoring, and I will first describe what's the rationale for monitoring these patients, and then some of the strategies and some of the limitations that we have. So I would say that monitoring patients using any type of non-invasive respiratory support definitely impacts clinical decisions by different mechanisms. First, the information that we get from monitoring can make us decide where and how often we're going to assess these patients. It can lead us to use specific adjuvant therapies, like, for example, light sedation or awake prone positioning. If we have some insight and some information of the inspiratory effort, as I mentioned before, it can help us decide between one device versus the other. Of course, perhaps the most fundamental decision that we make while monitoring these patients is the information that we get will feed our decision to transition to invasive mechanical ventilation, which is definitely a complex one. And even if it doesn't change our management, it gives us an awareness of the potential spectrum of outcomes of a patient to discuss with them and their families what they expect in their trajectory. An important concept that I think I described before, and most of you are aware, is that the failure of non-invasive respiratory support and the delayed decision to intubate can lead to poor patient outcomes, and there's a lot of literature that consistently shows this. In terms of strategies for monitoring, we could conceptualize strategies based on purely respiratory parameters and single, like oxygenation, respiratory rate, inspiratory effort, the tidal volumes, if we have capacity to monitor the tidal volumes, and the subjective assessment of the work of breathing. There's also composite scores, which became very popular, in particular for high flow nasal oxygen, like the ROX index. We can also use systemic parameters like the level of consciousness, heart rate, the blood pressure, how stable or not these patients are hemodynamically. And there's a number of composite scores. One of the most popular is the HACR index that involves both systemic and respiratory parameters to come up with a score that highlights which patients are at higher risk of requiring invasive mechanical ventilation. This is a very nice example of how monitoring can be helpful. In this study conducted by Tonelli in Italy a few years ago, they placed esophageal balloons to patients that were having hypoxemic respiratory failure, and they followed them over time once they started non-invasive ventilation. What they observed is that the lack of reduction of inspiratory effort in the first 2 hours after initiation of NIV was the one factor that was mostly associated with the risk of intubation within 48 hours. So more evidence that inspiratory effort might be a key aspect to assess in these patients, and not only as a factor to select between the strategy, but also to assess treatment response. And the techniques to monitor these patients can go from really simple, like assessing patients, to really sophisticated, like esophageal balloon and EIT. So on the left side on the screen, we have physical exam. We have some calculators like the ROX index. In patients that are receiving invasive ventilation, we can look at the waveforms. And Georgie Roman Sarita, who's one of the respiratory therapists that leads the practical platform, has just published a very nice study looking at the validation of the occlusion pressure and P.1 in healthy volunteers, including myself, that are receiving non-invasive ventilation via face mask. We can also look at the diaphragm thickening fraction as a surrogate of inspiratory effort. Tonelli and colleagues described a method looking at nasal swings with measuring the drop in the nasal pressure to have an idea of the amount of effort that that patient is doing. Of course, an esophageal balloon and EIT are a bit more sophisticated, but perhaps can give us a bit more granular physiologic data on the effort and the tidal volume distribution of these patients. An important aspect of what happened over the last few years, and in particular after the pandemic of COVID-19, is that the use of high flow nasal oxygen has really moved out of the ICU. And in many centers around the world, high flow nasal oxygen is quite common to find in the medical ward. So one thing to bear in mind is that that transition of high flow nasal oxygen from the ICU to the medical ward also led to less capacity to monitor these patients. And perhaps it's something that needs to be assessed how safe it is overall. So we're getting to the final part of my talk, which I'm going to describe some future directions. First, describing how the wide use of non-invasive respiratory support has impacted the ARDS definition, some areas of uncertainty, and finally some ongoing research. So as I mentioned before, high flow nasal oxygen after the Ferreyro study, and in particular after COVID, really became massively used in particular in developed countries, to the point where a group of researchers proposed that we should revise the Berlin definition that did not really include a specific component of high-flow nasal oxygen to include patients receiving high-flow nasal oxygen in this new proposed global definition. So in addition to the classic Berlin definition, they proposed that we should also consider the definition of ARDS in patients that are receiving high-flow nasal oxygen of at least 30 liters per minute with similar oxygenation targets, also adding the SpO2 FiO2 ratio, recognizing that not all the patients with acute respiratory failure and in not every center it's possible to measure arterial gases. The bilateral opacities component can also be added by assessed by ultrasound based on their definition. And in resource-limited settings, the criteria for PEEP or specific oxygen support might not really be considered to be able to define ARDS and recognize patients that are at risk and should receive treatment of that. This is an interesting study conducted by Ranieri and colleagues during COVID-19, where they assessed patients that were receiving high-flow nasal oxygen and subsequently intubated, and they assessed how the severity of ARDS or hypoxemia would be classified right before they were intubated on high-flow nasal oxygen and right after they were intubated. And the interesting finding there is that when patients on high-flow nasal oxygen are classified in mild, moderate, and severe respiratory failure, and they then are subsequently intubated, most of them would still meet the criteria of severity and would still meet the criteria of ARDS. So only those highlighted in green there, so 7% of that cohort, when they were intubated because of the more effective positive pressure applied, really lost the definition of ARDS. So this, at least in theory, to me, highlights that the proposed global definition has some good rationale, because really patients on high-flow nasal oxygen probably meet the definition and should be treated as ARDS patients. So these are some areas of uncertainty that I think we still have, among many others, in this field of non-invasive respiratory support. The first one at the top is surrounding the device selection. And I would say that helmet NIV and whether it can be widely applied in centers that do not have a strong preference or strong long-standing experience with its use, it's one topic that definitely needs a bit more research. Definitely the sources of heterogeneity of treatment effect and perhaps potentially an individual patient meta-analysis of many of the recent studies conducted in this field might be helpful to identify some individual patient characteristics that make any of these devices more effective in this field. The optimal monitoring, as I mentioned before, in theory, it sounds really nice that we should monitor these patients and we should have lots of granular physiologic variables, but in particular for high-flow nasal oxygen, obtaining those variables is not straightforward. And not every center in the world will be keen to place esophageal balloons or use EIT in these patients. So perhaps having more friendly and easily to use at the bedside tools in the next few years might be helpful. I think there's a big gap, and I didn't talk about this, but I think there's a big gap in adjuvant therapies, how we should feed these patients, when and how safe we should mobilize these patients to make them more stronger, or at least decrease the risk of subsequent weakness, whether there's any potential sedation strategies that might help, for example, make some of these interfaces more tolerable, which are the optimal winning strategies. I think we're all pretty good to put patients on high-flow nasal oxygen, but we're not so good to win high-flow nasal oxygen, or we don't know what should be the approach to do so. And as I mentioned before, I think for hypercapnic respiratory failure and specific conditions, we definitely need more data on the effectiveness of other modalities apart from non-invasive ventilation. Our Canadian approach to try to address one of these limitations was the HONOR randomized controlled trials, which we just completed recruitment. In this study, we included patients with hypoxemic respiratory failure, and we randomized them to either a combination of high-flow nasal oxygen with sessions of non-invasive ventilation via helmet interface, aiming for at least 8 hours of helmet in the first 2 days of randomization. And comparing this with high-flow nasal oxygen, we looked at feasibility outcomes and also clinical outcomes like intubation and all-cause mortality. This was an open-label study, of course, and our target that we have just reached were 200 patients. It was a great experience to be part of the study, and here, for those interested, it's a video that we use to train DRTs across the 12 centers in Canada on how to place the helmet and how to select the initial ventilatory settings. And here, maybe a brief comment on one of the limitations of the study that I think might worth some discussion as well at the end, which was we at least conceptually identified 2 different types of centers. So in some centers, we observed that high-flow nasal oxygen was mainly step down to ICU intervention. So patients typically receive standard oxygen devices on the floor. Then somebody makes the decision to admit this patient to the ICU, and then they put them on high-flow nasal oxygen. And the decision for intubation, if it happens down the road when the patient is already in the ICU. And I would say this was the type of center where we had maybe less issues to recruit and randomize patients, because one of the inclusion criteria was that the patient needed to be in the ICU, so we could easily capture these patients. But we also found that here in Canada, there were some centers that practice more as Hospital B, where patients were started on standard oxygen on the floor, and they were transitioned as well to high-flow nasal oxygen on the floor. So really, the decision to admit this patient to the ICU and to intubate happened both at the same time. So as you can imagine, trying to capture a large amount of patients from these centers was quite challenging, because essentially we were missing these patients. Of course, being intubated was an exclusion criteria. So if the patients were admitted to the ICU at the same time a decision for intubation was made, or the patient was really in extremis, there was no point on randomizing the patient to the studies, because that's not really a population that we were interested. And of course, going back and randomizing patients to potentially receive helmet non-invasive ventilation on the floor was also not feasible. So a key limitation that I think also reflects a little bit on a significant change that happened after COVID, that really in certain centers, high-flow nasal oxygen became more a ward level type of support. And I would love to hear other thoughts on how safe that potentially is. So this is my last slide, and my final notes. I would say that non-invasive respiratory support has really a central role in patients with acute respiratory failure, that monitoring is key regardless of the device and the modality employed, even if it's high-flow nasal oxygen, and our capacity to obtain granular physiologic data, at least for now, is limited. And finally, that this is really an evolving field. As I was preparing this talk, I had to update many recent RCTs published in this area. And I'm sure that if I'm invited to talk about this topic again next year, this presentation will likely be different. Thank you very much. It was a great pleasure, and I'm happy to take questions.
Thank you so much, Bruno, for a really, really fantastic talk. And as you said, so much new and really fascinating evidence to include there. So yeah, a really, really wonderful overview of a dynamic and changing field. At this point, happy to open up to the audience if there's any questions or other thoughts for discussion. And feel free to raise your hand, or if you want to just unmute and ask a question, either way, totally fine. Bruno, maybe while the audience is thinking, I think the last points you were raising about some of the differences you were seeing in the different hospital contexts within the honor trial. I think maybe a broader question I was wondering about, as in more the beginning of the talk, you were talking about some of the evidence for helmet, which is really quite compelling. And it seems like there's been maybe successful, more regional uptake, but still many centers and countries really haven't thought about using helmet. I was wondering if you can talk about some of why that might be sort of beyond, say, when patients get intubated and some of the barriers to implementation.
Yeah, thanks, Richard. That's a great question. I honestly, I think about that a lot. I think there's probably two components on that. One is what I think I described, which is the clinical evidence for helmet NIV has been really promising in the sense of if you look at the effect estimates of small randomized controlled trials, like every single meta-analysis that has been conducted in the field, they all show some promise, like some quite extreme, if you want, effect estimates for important clinical outcomes, intubation, and even so for mortality in some of the studies. But perhaps none of these studies has been enough to convince the community and the health system that that this is really an effective strategy. And I think I agree with that, because when you look individually at these studies, they all have certain limitations. Either they were a single center study that was initially meant to study a specific thing and then changed to study the helmet, or it was stopped early for benefit, or it was conducted in places where helmet has a lot of uptake and enthusiasm, like Italy. And interestingly, I spent some time in Rome, and when they did these studies during COVID, they used so much helmet that when somebody got randomized to high-flow nasal oxygen, they had issues because people really wanted to put a helmet on patients. And I feel here we had kind of the opposite experience, where patients got randomized to helmet. It was a lot of work, which leads me to the second point. I think one of the key differences is like high-flow nasal oxygen is so easy. It's like it's a nasal cannula. There's two settings that you choose, and you just put it on, and that has led to a massive uptake, and perhaps to the use of high-flow nasal oxygen in settings where it's really potentially not very safe. And I would argue that there are some studies on withdrawal of life-sustaining therapies on patients on high flow, that as soon as they remove the high flow, patients die. So that kind of highlights that high-flow nasal oxygen is not standard oxygen. It's fairly a higher level of support, and maybe it's so easy to be applied that perhaps that's one of the reasons why it has shown so much uptake throughout the world, and definitely has more evidence, like has maybe also related to the same factor. It has been more widely studied because it's also simpler to be used. And you can do it with a ventilator, but you can also use it with a specific device that's a little bit less heavy than a ventilator. So I think those are some of the clinical and cultural factors that limit the use of helmet NIV. And I'm not saying it's wrong. Maybe I think it's right. Like in particular, the lack of consistent evidence, I think it's a fair explanation of why the helmet has not been seen so much uptake.
Yeah, fantastic. Thank you, Bruno. Any other questions from the audience?
Hi, how are you? Bruno, thank you for your presentation. I'm Marina Usico from Buenos Aires. I'm a respiratory therapist. And I wanted to ask you about hypercapnic respiratory failure, because we also use non-invasive ventilations for COPD patients and neuromuscular patients and patients that develop hypercapnia after extubation. And we have no new randomized control trials about that. So it's very difficult that new generations still use non-invasive ventilations on these patients that we are sure that we have to use it. So what do you think about it?
Hola, Marina.
Hola.
Yes, no,
¿Cómo
I,
estás?
bien, bien. I agree with you. I think I tried to highlight in that slide, like non-invasive ventilation was and still is the cornerstone of ventilation for patients with hypercapnic respiratory failure. I think physiologically we could agree that high flow nasal oxygen has some features that could be potentially attractive, but it needs supportive evidence to use it. I don't think we're there yet, and I think in particular for patients with acidemia and hypercapnia, non-invasive ventilation should still be the standard of care. I agree totally.
Thank you.
I see Glauco Plens has a question.
Yes, thanks, Richard. Thanks, Bruno, for the great talk. I wanted to ask you about something that I struggle with in current practice. Like when patients with ARDS are with the high flow nasal cannula, we cannot monitor tidal volumes and so easily. And we look at the respiratory rate, ROX index, things like that. But then if there is a decision to intubate, then something changes and we all care about, let's keep the tidal volume 6 ml per kilo, plateau pressure less than 30, things like that. But it's the same disease and supposedly the same pathophysiological processes happening, or at least very similar. So nowadays, how would you recommend that we can monitor tidal volume or anything to monitor the risk of lung injury during non-invasive ventilation or high flow nasal cannula?
Yeah, yeah, absolutely. I agree. I have I usually give a talk to the fellows at Mount Sinai where I work, that I present 3 cases of patients with respiratory failure. One is like a patient intubated, sedated, paralyzed. The other one is a patient that is recovering, like transitioning to spontaneous breathing, and the other one is a patient that comes from emerge with high flow nasal oxygen. And I just to highlight on how much we really focus on numbers in the first one and increasingly on the second one, and really we have very limited information on the third one. So the picture you're framing is, I think it's very spot on, and I think we do not have validated methods to estimate tidal volumes on patients with high flow nasal oxygen. The EIT could be a strategy, but again, I think this is attractive from a research point of view, but I tend to think that people really like simple things, and to become widely available in all ICUs, EIT, or even placing a esophageal balloon to these patients, it's really not something that I think will be sustained over time. So we definitely need to find methods that are simpler and can help us at least have an idea of the tidal volumes or the effort or both. Maybe one method that is a bit more simple to highlight is that I have not used, to be honest, but it's the one that I described from Tonelli, which is like the nasal swings. That is a bit less invasive. And it seems that we had Roberto Tonelli as a visiting professor a few months ago, and it seems that in his unit in Italy, everyone on high flow nasal oxygen really gets the measurements of that, and they use it clinically a lot. But again, I think it still requires some expertise and has not really captured uptake into other settings. Ultimately, having something integrated with the ventilator that can read the information from maybe the airway flows through the cannula and give us an idea of the effort and the tidal volume would be really helpful.
Perfect. Thanks so much, Bruno.
And I see we're at the top of the hour. There's one question in the chat. Bruno, do you have a moment to answer that? Of course, a lot of respect here and everybody's time.
Veracing, in your opinion, what is the best option for non-invasive mechanical ventilation? Dedicated NIV with advanced leak compensation algorithms and greater use or conventional invasive mechanical ventilators adapted for NIV? It's a great question. I personally, again, there's really no evidence to support this, and it's all about preference. In our unit, we use conventional invasive ventilation. In the last 5 years, I rarely remember a case where we did non-invasive ventilation through a dedicated NIV ventilator. And the practical aspect of using invasive ventilators, like I think ICU conventional ventilators have been getting better and better to provide effective non-invasive ventilation. And one of the additional benefits of using invasive ventilators for NIV is that if the patient gets intubated, then you can still use the same ventilator without needing to change to provide invasive ventilation. In my unit, in the last few years, for some reason, we are using only servos, so we can also use high flow nasal oxygen. So that's very handy because same device, and we can provide invasive ventilation, high flow nasal oxygen, and non-invasive ventilation either via face mask or a helmet. But that's honestly speaks a bit more about my practice and convenience rather than evidence.
Wonderful. Well, Dr. Ferreyro, thank you again for the really fantastic talk, and thank you to the audience for your questions and participation. I think Charissa has put a link in the chat for the post-conference survey. Would certainly appreciate if you would just take a moment to fill that out, and otherwise we'll wish you all a wonderful rest of the day. Thank you so much, everyone.